Okay, Dr. Nadhaporn, I think we're good to begin.
Oops, gotta share that again. Uh-oh, I cannot share. Oops. Okay. Hello, everyone. Thank you for joining and welcome to the CLAAS Connect Rotator Cuff organized by CanMed. We have 3 topics to be presented today on the rotator cuff, which will be followed by a joint 10 minutes question and answer session. Please type your question in the chat or the question box on the right, and we will answer them at the end of the webinar. Before we start, I would like to introduce the other members of today's panel. We have Dr. Fucai Han from Singapore, who will be presenting on double rotator cuff repair, and Dr. Jia-Lin Wu from Taiwan, who will be presenting on the partial rotator cuff tear, take it down or fix it in situ. So this is my presentation. The topic of presentation will be the tip and trick for the rotator cuff repair using all-suture anchor. Next. Okay, this is my 2 campuses of the hospital. This is my disclosure. There has been 3 types of all-suture anchors that has been the benefits of that has the lesser loose body complication from if you lose the anchors, and there is no distortion when you see on the MRI, and when you make the hole, small drill hole can be obtained by this kind of all suture anchors. It has 3 materials characteristic of the suture. It is the braided suture. Normally we use the number 2, or the small tape, or the regular one, like the regular tape. For the biomaterials, all suture anchors made from the ultra-high molecular weight polyethylene. It is a non-absorbable, and each brand has a little bit different for the abrasive properties. Like they claim that high-fi tape has lesser abrasive effect compared to the fiber wire or fiber tape. Sorry. There has been the many study observing the characteristic of the tape and the suture braid, like in bovine model, has been done in the ox, they cut the infraspinatus and see that then when they coverage with this different kind of suture, like the braided suture and the tape, they find that the tape has the greater footprint contact pressure and with a higher ultimate failure rate. And the mode of failure mode is the suture to tendon interface. And they also done in the clinics by observing at the 6 months after the operative rotator cuff repair using double row transversus equivalent technique with a 50 patients with tape and 100 with the suture like the regular one, and they found the similar repair rate. So from this observation, we found that there's no big difference for the tape and the suture braid. The mechanical properties of all-suture anchors. Another study was conducted comparing between the conventional anchors and the all-suture anchors, and they found that most of the conventional anchor has the greater tensile strength, but in between the group of the all-suture anchors, we found that the Y naught RC is above the average, and as well as when we make the cyclic load, and we found that the displacement is in the average as well, and the failure mode will be the ankle pull out. There has been two techniques of insertions. The first one that recommended by the company is we call punch and put. I call this one using the 2.8 mm pilot hole and then put the anchor ends. It is good for the hard bone like this. But if you have the soft bone that you can be evaluated before the surgery, the promptly put or self-tapping will be introduced like this one. You just point to the area that you would like to put the anchor on, and then you punch it immediately. It will purchase underneath the subchondral bone. So the reasons of some people say, like in the study of the Burkhardt Datesman angle has been published in 2009, they say that they need to put the anchor in the 45 degrees like this, even though it will be lost some of the strength. But for the all suture anchors, even you put the anchor on this way or in this way, it will make the suture ball underneath the subcortical or subchondral bone without not depends on the angle of insertion. So it should be the benefits of this kind of anchor suture. So another study to emphasize that the angle of the insertion does not affect is that they compare between the all-suture anchor and the regular one, like the cross FT 4.5 mm, and then they put the anchor into 45 degrees from the humeral head, or 90 degrees or 110, and see that the pull-out strength, something have different from the previous study from Dr. Burkhardt is that at the 90 degrees of the anchor insertions, they found that the pull-out strength is the highest one. And also the stiffness of the all-suture anchor is higher than the regular or conventional anchor. So the insertion angle does not influence the pull-out characteristic of all-suture anchor, and the angles of 90 degrees reaches the highest pull-out strength. When you question about the osteoporotic bone, especially for the humerus, it has an effect. The answer is yes, because osteoporosis, the process has been start with the trabecular bone first and then the cortical bone. And this all-suture anchor may not be so good for this kind of bone. This is the example of the patient of 30 years old and 70 years old. And as well as the all-suture anchor claim that it should reduce or or decrease the bone damage, and you need to choose the right person, that is, have the adequate cortical thickness. One study, actually it's the same study, but conducted with the micro CT measurement to measure the bone density, the bone loss of the anchor in different insertions. Like this, they say that the all-suture anchor has lesser volumetric bone loss than the conventional, and it has the narrower cortical defects. So in the case that you would like to preserve a lot of the bone, you should use the all-suture anchors. And the best way is to preoperative evaluation of the cortical thickness and try to avoid the intraoperative decortication of the footprint. We are talking about the cortical thickness evaluation of this area. This area is the location of the ankle placement, and osteoporotic bone may affect the pull-out strength. Actually, I tried to find the standard protocol for shoulder BMD, and I found that there is no standard one. So when my observation, how could I take a look that it's a good bone or bad bone? I take a look at T2 weight compared to T2 proton density, and I found that the T2 proton density can represent a good or the bad cortical thickness like this. So from my practice, I use this kind of signal to predict that which kind of ankle that I will use. As well as the ankle migration, that depends on the shoulder BMD. There has been one study, Young Ri and his colleague conducted the study of the all-suture anchor by MRI study for the time 0 and time at 10 months in the single roll with repair with all-suture ankles using the 3 triple load. And at the time 0, the depth of the anchor between here and here was high in the high BMD group. And the time passed by at 10 months after the surgery. The depth of the anchor was the most shallowest is on the lower BMD, less than 0.4, and it moved close to the subcortical bone. So the interesting thing is that the overall repair rate is just only 2.3 by Sugaya class 5, and it has the same constant score, even they have the low bone density or high bone density. So the bone density may not be effect for the clinical function. So the best way to preserve is reduce the removal of the cortical of the footprint like this. So you need to keep in mind that if you would like to use all-suture anchors, you need to keep a lot of cortical bone like this. And there also the repair construct between tape and wire. Wire, I mean this the suture braid. There has been the construct with using the suture braid and then use a tape with the one lateral transocean equivalent anchor and 2 TOE in a different way of construct. And they say that the tape created a greater contact pressure and the area compared to the wire, and it has the same gap formations like this. So this is the area, the red area is the dot of the contact area, and they found that the 4 anchor, 2 on the medial and 2 on the lateral, show the best the greatest contact area. Okay, so we introduced that if you can perform the double roll repair with the suture bridge techniques, it should be the best for the contact pressure and area. Talking about the healing, all-suture anchor repair has been studied that how good for the healing. The 20 patients conducted the double roll supraspinatus repair, and they used the MRI with a special techniques that's called true fast imaging with CD state precession at 1 year after the surgery with this classical double roll. And they found that one of them, of the 20, had encapsulated cyst from this. So what happened is that they got a cyst. It shows that it got the mature cyst, or the cyst has made the tendon retear. So they most of them is not has no cyst. So they report that the retear rate is about 1/4 of all of the cases, but the constant score is the same. So it means that All-Suture anchor can produce a small cyst, and most of them can have the good constant score pulls up with some small retear. And most of them has some bone ingrowth into the anchor. So it is the proof that the All-Suture anchor allow normal tendon to bone healing. That you've seen from this special signal that the healing of All-Suture anchor repair has the bone ingrowth. You can see that this is the cortex of the humerus, and it is the so-called like the cortex of the gap that has been filled up with some new bone formation. So it proves that it has been healed. Very good. So my conclusion, if you would like to know that how good or bad for the bone that you will put the anchor in, you used to use the punch first, and then you use the punch as a finger, and then you put the anchor later on. For the pre-op bone quality assessment, if possible, in the future, I don't know, we can use the shoulder BMD as one of the clinical judgment that we can use the conventional anchor suture or the All-Suture. And the next one, if you need the tight medial roll compression, like you have the very, very tight tendon cuff, you need to use the medial roll, and you will suture or tying with the braid suture. Instead of you have the good soft tissue and you would like to share the load and need to have the optimal healing, you can use the double roll and use the suture bridge techniques without suture or without tying the knot on the middle roll like this. So this is my conclusion, and this is the take-home message. The cortical thickness is the critical factors for All-Suture ankle stiffness, and any insertion angle of All-Suture has no effect on the pull-out strength. And you can use wire or tape. It has the advantage depends on the tendon quality. Before we end of this, I would like to invite you, if the situation of the pandemic has improved, next year we will still have the TOSM and APCUS meeting in July next year. Thank you for your kind attention. The next, I would like to introduce Dr. Fucai Han for his topic. Dr. Han, please.
Okay, I need to share my screen.
Yes, I am using you as the unshare. Cancel. Now, can you? No.
No.
Okay. Okay. Make the participant presenter. Round icon. Change the presenter. Okay, I think that, can you now?
Yes, I can.
Okay, sorry about that. All right.
No problem, no problem. Okay, yeah. So thank you, Dr. Nadhaporn. It was a very good talk. So good afternoon, everyone. I'm Dr. Han, a consultant orthopedic surgeon for shoulder and knee from Ng Teng Fong General Hospital, part of the National University Health System in Singapore. I thank CONMED for inviting me to give this talk. So this is my hospital, which is a 700-bed hospital with acute emergency services located in the west side of Singapore. It is part of the National University Health System. My practice here involves both public and private work, focusing mainly on shoulder and knee sports surgery. For today's talk, I will present a case and my technique in repairing a torn crescent-shaped rotator cuff tear using the CONMED implants. So this is my patient, a 58 years old right-handed gentleman who works as a crane and prime mover driver in the construction field. He had a fall onto his outstretched right arm, sustaining an isolated right shoulder injury. He was seen in my shoulder clinic at 1 month post-injury with persistent pain and weakness. There was reduced active range of motion of his shoulder with painful and weak supraspinatus on examination. So MRI was done, which showed a full thickness complete width supraspinatus tear that's retracted to the medially to the level of the humeral head. The size of the tear is about 2 to 2.5 centimeters, a moderate size tear, and there's minimal fat atrophy changes seen on the MRI scan. So this is a 58 years old active and healthy gentleman whose work requires overhead motion and strength, who sustained a moderate sized cuff tear without any significant arthritis or muscle atrophy. So we can manage it non-operatively or surgically, either using open techniques or arthroscopic techniques. For me, because of the above factors, I elected to perform an arthroscopic double row rotator cuff repair for this patient. So for my rotator cuff surgery, I positioned the patient in a beach chair position using a hydraulic arm holder. I routinely use 4 to 5 portals for my double row repair. I use a standard posterior viewing portal and an anterior superior portal for glenohumeral work, which can act as my suture management portal as well. I will have a lateral working portal, and often I need an additional posterior lateral viewing portal to gain better visualization of the cuff and the greater tuberosity during the repair. I will have a small suture anchor portal that's just lateral at the edge of the lateral ecomium for my medial row anchor. I will always use a spinal needle to check my trajectory prior to making these portals, as the position might change once the shoulder starts to swell. So for my double row rotator cuff repair, the instruments I find useful are the following 3. This is the anti-grade auto capture passer, which allows self-retrieving of the sutures after passing through the tendons, reducing the complexity in sutures passing in this surgery. For tighter space and more difficult angles, I like to use this reusable CONMED T-handle that has made arthroscopic rotator cuff repair much easier. I'll talk more about this instrument as I understand it might not be available in all countries for now. I also use the adjustable retractable cannula that helps me to retract away the soft tissues to improve visualization and enhance sutures management. For implants wise, in the past, I like to use the bioabsorbable or PIC 4.5 millimeters medial row anchors. However, I find that sometimes there's not enough space apart at the cartilage margin to put more than 1 medial row anchor, even in a moderate size tear. So currently, if the bone is of good quality, I like to use this smaller 2.8 millimeters all-suture anchor that Dr. Nadhaporn has mentioned earlier, as there's less bone removal required. Also, the anchor and the introducer are quite malleable, hence avoiding any breakage of the implants in the shoulder joint. Furthermore, this suture anchor comes with a suture tape, also known as ribbon, or standard tape options, which provide and allow better compression of the double row repair. For the lateral row, I like to use this 4.5 millimeters pop lock knotless anchor to avoid any issues with knot tying, such as type 2 retear of the calf or any knot abrasion or irritation. Also, this anchor allows me to put multiple sutures and tapes, at least 4 sutures or 2 tapes and 2 sutures for strong natural knotless fixation. With regards to the T-handle that I mentioned earlier, I was first exposed to it a few years ago when I visited the designer of this instrument, Prof. Yong-Gure in Seoul, Korea. He taught me how to use this instrument well, and since then I've never stopped loving it. With this instrument, I can firstly reduce the cost involved in my surgery, as it is a reusable instrument. Secondly, this instrument has a sharp tapered tip, which allows it easy to pierce through the thick calf tissues. Also, it can be performed in a percutaneous fashion, which is especially useful if our portal placement does not allow easy access to the calf using anti-grade suture passing devices. Furthermore, as compared to the other piercers, such as the Arthro Pierce, Bird-Beak, it's only 1.5 millimeters, which allow easy access and navigation in tight spaces. Lastly, the T-handle design makes it overall ergonomically easier to handle this instrument. So after using this device, I very rarely use other thicker instruments such as the other piercers, which in my opinion could cause more damage to the healthy intact rotator cuff tendons. So this T-handle can be inserted percutaneously via the anterior superior portal, the posterior portal, or medially via the navicular portal. I prefer putting this through the navicular portal as it gives me a straight shot through the tendon in a retrograde fashion without risk of damaging other structures in the shoulder. This is a video showing how the T-handle can be used. After piercing through the full thickness of the calf, I use PDS suture as my suture shuttler. We can also use the wire loop as suture passes. I use the PDS to shuttle a non-resorbable hi-fi suture through the rotator cuff via my working portal. This step is repeated a few millimeters adjacent to the previous pass using the T-handle, and I shuttle the other end of the suture, hi-fi suture through this second PDS suture, hence forming an inverted mattress suture as you can see. I retrieve both sutures to avoid any suture breach as they are passed percutaneously. So for repair configuration wise, in double row repair, in the past we perform knotted medial and knotted lateral double row repair, but we know that it's time consuming and risk tendon strangulation leading to a type 2 retear of the calf, making revision surgery very tough. So there's a transition to a more knotless transosseous equivalent configuration, either by tying the medial row, but this also risks the complication of a type 2 calf retear at the musculo-tendinous junction due to medial row strangulation. So now I mainly perform the transosseous equivalent knotless double row repair, but there's a possibility in suture slippage. However, with the advancement of stronger lateral row anchors that can lock the sutures, I do not see this as a problem at this point. So this slide shows further examples of knotted and knotless configuration, such as the knotless TOE double row anchor technique that I usually use with 2 medial and 2 lateral row anchors without any knots tied medially. We can also use the All-Suture anchor sutures for knotted repairs, such as the knotted medial mattress, the medial pulley, medial ripstop, or simple stitch techniques with the 2 pairs of the number 2 sutures tied at the medial row, and then with the tape subsequently passed to the lateral row. So I use a combination of these techniques, but I prefer this knotless technique, which I will explain at the end. So I will display a video demonstrating the knotless double row calf repair technique using the mentioned portals and implants. I first perform a diagnostic glenohumeral scope viewing from the standard posterior viewing portal. I'll perform any glenohumeral work needed at this point, such as subscap repair or biceps tenodesis. There's a full thickness calf tear that you can see from the glenohumeral side that's medially retracted to the area of the humeral head. I would then perform a subacromial birsectomy and prepare the footprint for the repair. I perform a birsectomy to have a clear visualization of the calf, release any adhesions that might limit the mobility, clear the space to allow smooth passing of the sutures without any interference from the soft tissue. At this juncture, I will also prepare the lateral gutter for my lateral ankles. As mentioned by Dr. Nadhaporn, the footprint is gently decorticated to prepare for a biological healing of the calf tendons. I would then assess the calf mobility. I will perform additional releases as needed to create a tension-free repair. I would use the ConMed adjustable cannula for my working portal. This cannula has a retractable flange, as you can see, that can retract the deltoid muscle and soft tissue and also prevent soft suture bridge formation. Next will be the medial row anchor. I use 2.8 millimeters All-Suture anchors for my medial row that has 2 limbs of tape and 2 limbs of sutures each. As you can see from the video and also from the previous presentation, the All-Sutures anchor are small, yet with good pull-out strength. I can easily put 2 medial row anchors even in the medium-sized tear. A medial row anchor is placed at the cartilage margin through my suture anchor portal. I will always pull on the suture anchor to ensure that it's deployed and that it's strong enough to withstand a pull-out force. So the sutures and tapes for the medial row anchors are then passed through the tendon in a horizontal mattress fashion using the AutoPass auto-capture device. Alternatively, we can use the ConMed T-handle that I've shown earlier. This is especially useful if we cannot get a good angle of passing in an antegrade fashion or if the subinguinal space is tight. So these steps are repeated for the posterior anchor of the medial row, separated as far as possible apart from the first anchor. So I pass the sutures a few millimeters to the previous strand of suture, and after each pass, I always retrieve the sutures and bring out through my anterior superior portal as part of my suture management, as you can see here. So lastly, all these medial row anchors sutures are brought out and anchored onto the lateral row anchor. I'll deliver 1 limb of suture and 1 limb of tape from each medial row anchor to be incorporated into my lateral row anchor using a pop lock 4.5 millimeters anchor. This will give me 2 limbs of tapes and 2 limbs of sutures for each anchor. The steps are repeated for the posterior anchor for the lateral row. The sutures are cut to give a knotless configuration. So this completes the repair with a total of 4 limbs of tapes and 4 limbs of sutures. So instead of having both sutures and tapes, most of the time, I'll just use the tapes in All-Suture anchor, and I'll just pull out the sutures from the anchor itself. This will give me a speed bridge type of transosseous equivalent configuration for the 4 limbs of tapes, which can also provide good compression of the footprint and the repair. So this is just another photo of another patient to clearly show how the suture configuration would be if I just use the tapes alone without sutures in the All-Suture anchor. So after surgery, I put my patient on an arm sling for 6 weeks. I allow them to take off the sling to start pendulum and early passive motion exercises during this time. They can proceed with overhead and active exercises at 6 weeks post-op, with strengthening at 10 to 12 weeks post-op. So this is the patient at 6 months with a painless and functional range of motion of his shoulder. He has good calf strength and he's back to work as a driver, and he can perform all his activities of daily living. So I will summarize my choice of technique in my last few slides. So why do I do double row instead of single row in a medium-sized tear and larger tears? Because there are several systematic reviews and meta-analyses of level 1 and 2 studies that have shown biomechanical superiority and a lower rate of retear when double row was compared with single row repair types. This is especially so in larger tears more than 3 centimeters. Also, due to better restoration of the footprint, increased footprint contact pressure and less gap formation, it's postulated that double row repair can lead to a better healing environment at the tendon bone interface, and this will allow us to start more aggressive post-operative rehab. So why do I go knotless now? Because knotless are straightforward, there's less operative time, and for simple, straightforward crescent-shaped tear, I would prefer this technique as it's faster. Also, I wouldn't be concerned about knot abrasions or impingement. More importantly, as I mentioned earlier, knotted repair at the medial row has been associated with strangulation of the calf, limiting the blood supply. And this has led to potential type 2 repair at the musculotendinous junction, as described by Dr. Cho and Prof. Yongguye in AJSM. So they have additionally detected statistically lower rates of repair in the knotless transosseous equivalent group compared to the knotted group in a series of 110 patients. So this finding was also found in a study by Dr. Peter Millett, comparing knotted versus knotless double row repair. So although there were no significant differences in clinical outcomes between the groups at the mean follow-up of 3 years, patients with a knotted medial row repair were significantly more likely to have a MRI diagnosed full thickness rotator cuff tear as compared to the knotless group. But don't get me wrong, I'm still an advocate in arthroscopic knot tying that differentiates sports surgeons from the rest. Although I do knotless repairs for standard crescent-shaped cuff tears, I still tie knots in my repairs, mainly for margin conversions of large U-shaped tears, L-shaped, reverse L-shaped tears, and also for larger retracted tears, I will tie knots for a ripstop configuration that I've shown in the pictures earlier. So why all-suture anchors for my medial row? I think Dr. Nadhaporn has already presented very well. But in summary, because it's smaller, it allows for more points of fixation, and also it's bone preserving, and there's improved access as the anchors and the introducers are malleable, so it doesn't break that easily. Also, I use it in the glenoid labrum or the hip labrum repair, as I can insert them through curved drill guides. More importantly, there's potentially less peri-ankle cyst formation. In this study performed in Korea, it has been shown that 10.8% post-cuff repair cases are associated with this peri-ankle cyst formation. Although in this study it's not statistically significant, but we can see that all suture anchors are associated with less peri-ankle cyst formation as compared with PICC and bioabsorbable suture anchors. And in this study, we know that repair rates correlates with greater peri-ankle cystic reaction. So in summary, there are many methods of repair, including ripstop, suture bridge, split bridge techniques, etc. There are also many new instruments and implants in the market. We will find one that those that work best in our hands with the support of relevant literature. So biomechanically, and as what evidence has shown, double row repair should be performed for medium and larger size tests. So this brings me to the end of my talk. Thank you, and 감사합니다. Next, we will have Dr. Wu from Taiwan to present on his topic.
Okay. Can you see the screen?
Yes, Dr. Wu.
Yes. So I can start it, right?
Yes, I think you just start your presentation on the top left.
Okay. Hello, everyone. Good afternoon. I'm very happy to give a talk about the talk today. And then my talk today will be the topic today is the partial rotator cuff tear. Take it down or fix it in situ. I'm Jia-Lin Wu. I'm from Taipei Medical University Hospital, and also an associate professor in Taipei Medical University. This is my email. If you have any problem, maybe you can contact me. I have no financial conflict of disclosure. This is my hospital. The totally available base about like 700. One of the most important part of my hospital is just near the Taipei 101. So if everyone have a chance to visit Taiwan, maybe you will come to 101 and you can see my hospital. Okay, so my talk is about the partial rotator cuff tear. And the partial rotator cuff tear represent a common cause of shoulder pain and disability in the adult population. And the partial tear are more common than full thickness tear. The supraspinatus tendon is the most usually involved. Sometimes the tear can involve the subscapularis tendon. So the prevalence of the partial tear ranges from 13% to 32%, strong related to patient age with a linear increase after the 5th decade of life. The articular side tear is much common 2 or 3 times than the bursal side tears, especially in the overhead athlete. So about the pathogenesis, the different mechanisms have been described in the pathogenesis of the partial tear, including the intrinsic factor such as the traumatic events and age-related degeneration change to the tendon. Also, the extrinsic factors such as like impingement and the posterior superior granule impingement, and also the bicep tendon instability. Sometimes the pathogenesis differs according to age. In young athletes under 30 years old, the internal impingement may be represent the main cause of partial tear. Around 40 to 50 years, maybe the post-traumatic tears are more frequent. But over the 60 years, the degeneration change is the main cause. So for the articular side partial tear is most often associated with the underlying instability of the shoulders. But for the bursal side partial tear, it's correlated with the impingement tight syndrome. For the intratendinous tear, the mechanical shear stress between the superficial and deep layer, they're different from the corneal tendinopathy and from the partial full thickness tear or rotator cuff. So there's no consensus in the literature concerning about their etiology. Talking about the classification, I think there are several classifications for the partial tear can be adopted, but I think the element classification based on the arthroscope findings still is the more easily used and easily communicated between the surgeons. I think divided the partial tear is the articular surface tear and the bursal side tear. And it also divided 3 grades based on the size of tear and the tendon involvement. Okay, so for example, like an element grade 3 is a tear more than 60 millimeters and the tendon involved more than 50%. Also, some like a nomenclature subtype of the partial tear or the articular side we still need to define. Like most often we will know about the pasta lesion, and some cases we will call it a ring-rim tear. A ring-rim tear is a very common the articular side partial tear of the rotator cuff. But if the ring-rim tear with the denomination, so we will call it a pasta lesion. So generally we can divide all the partial tear to 2 groups. One is the footprint involved. The other group is the footprint intact. So if the footprint involved, most often is the ring-rim lesion and the pasta lesion. And the other is only the footprint intact, the tendon involved, maybe a stairs, the pan, and say the lesions. Okay, so let's talking about the non-operative treatment. I think that every case before the surgery, we will try the non-operative treatment first, especially for the partial tear. So initially, maybe you can try some like NSAID for pain control and inflammation control. And also we need to give some like activity modification, for example, like avoidance of provocative activity. But if all the condition getting better, maybe we can prescribe a supervised physical therapy for 2 to 3 months. And then if the recovery is still pretty good, maybe we can try a sports-specific training program to go back for the game. And then sometimes during this period of time, maybe the subacromial cortical injection for the initial pain control and also facilitate the patient comfort during the physical therapy. Okay, so now the problem is it's okay to do the surgery after 3 to 6 months conservative treatment. According to the recent publication, there is no difference between the immediate surgery or after 3 to 6 months conservative treatment. The clinical result is similar. Okay. So for the non-operative treatment, it's more likely to be successful, especially for the a traumatic partial tear, and also the tendon involved less than 50%, and also the non-dominant extremity. And these lesions may progress in size and become symptomatic over time. We can see a lot of biomechanical and histology study, and also the clinical evidence can prove this concept. Recently, the Keener also the perspective evaluate the patients with a symptomatic partial tear. So the tear progression in the 44% of the shoulders, and the median time for progression is about 3 years. And half of the patients may experience different kind of pain. So therefore, the periodic monitoring is recommended, especially in active young patients, despite successful conservative treatment. Okay, so if the conservative treatment fail, what is about the operative treatment? The surgical indications, I think the most often agree that the repair leads to a better result for the partial tear, cuff tear, more than 50% of the cuff thickness, and less than 50% the tear, the debridement with or without the acromioplasty is the choice. But from the literature, I will choose the Andrews, the Dr. Andrews, the surgical indication. I think it's more appropriate, and the surgical indication is according to the percentage of tendon thickness involved. If the tendon tear less than 50%, they will choose the simple debridement. And if the tear between 50% and 75%, maybe we can repair in situ. If more than 75% with delamination, maybe we can completion of the tear with repair the lamina and reattach to the anatomical footprint. But if for the elite overhead throwing athlete, if the small less than 25% the partial tear, maybe debridement is very good to allow most of them to return to the competitive pitching. So for my surgical technique, like for these cases is a bursal tear. Sometimes from the MRI, it's very difficult to differentiate. It's really just a partial tear, or sometimes it will almost a complete tear. But for these cases, the patient, because of conservative treatment, fail and still feel pain, so we recommend to do the surgery. And during the surgery, we can see from the surgery technique, you can see there is a bursal tear. It's almost through into the joint, but the articular side is still partially intact. So it defines the bursal side partial tear. So we try, because the tendon quality is pretty good, so we try to do the in situ repair using the double row technique. And then from the intra-articular, we can see the very good cable sign. So the reduction is pretty good. And this is a case of an articular side tear. From the MRI, we just can see some high signal within the tendon, and also the patient still have a very severe shoulder pain. So we try to do the diagnostic shoulder arthroscope, and then if it is necessary, maybe we try to repair. So this case is during operation. You can see the bursal side cuff. Look, the quality is pretty good. Okay, so if for the articular side, I would like to use the 1.8, the why not flex, because there is an angulation sheet, so you can introduce your All-Suture anchor is much easier to the footprint, and then use the number 18 needle to retrieve use the PDS and then retrieve all the fiber wire to the subacromial space. Okay, and then if it's okay, I will still fix it in the double row. So this is the after surgery. So now we need to discussion about when will we need to do what kind of a condition we should do the in situ repair or complete the tear to repair. So for the first question is about the tendon involved less than 50%. What kind of a procedure we should do? Maybe from all the case series, the result shows the arthroscope debridement, the less than 50% tendon thickness debridement with or without acromioplasty result in favorable outcome in most of the cases. Okay. So how about the in situ repair of a partial tear? From all the results, we can see that for partial tear in volume more than 50% of the tendon thickness, in situ repair has proved to significantly improve pain and functional outcomes for articular for either side of the tear. There's one paper mentioned about the better result could be expected in patients with less tendon retraction and a larger footprint exposure of young age. And with the traumatic history, we'll have a much better good result. So when we do the in situ repair of partial tear rotator cuff, do we need to do the acromioplasty? Okay, so from all the available series, we can see that there's no difference in the cases of partial tear in situ repair with or without the acromioplasty. Recently, there's one study is the in situ repair without the acromioplasty also have a significant functional improvement and pain relief. So whether or not the acromioplasty is necessary in addition to in situ repair is still controversial. Okay. So how about for the tear completion repair? Okay, so here there is the 2018 and 2020 have two animal study to show that the tear completion technique can give a very good result, and also the case series also show the same result, can get a very good result. And how about the repair, the in situ repair and the conversion to full thickness tear? Okay, only few available series we can see here. The result shown a similar result following the both technique. Okay, so is the in situ repair or conversion to complete tear have which one has a more higher risk of postoperative stiffness? From the result we can see here, recent result is that there a similar rate of stiffness, but from the previous study we can see there is a trend for a higher incidence after the transtendon technique. Okay, so how about the in situ repair of partial tear return to sports? The CLAAS reported a 683 the athlete. Their result is a 60% returning to play in the subgroup of a partial thickness tear. I think the Rossi in the 2019 report a very good study is 70 athletes with a partial thickness tear treated using the arthroscope in situ repair at a minimum 2 years follow-up. They shown that 85% of the patients were able to return to sports, and 78% can go back to the same level as previous to the injuries. Also, the functional outcome is pretty good. The mean delay in return to competition was 5.6 months. Okay, the non-collision and non-overhead sports return significantly faster to sports than the other patients. The mean is about around like 4 months. So there's no significant difference in the type of tear, age, previous level of play, and the mechanism of injury. So for me, I want to share my experience. I think the partial tear of the rotator cuff is still very challenging. One is the clinical, the preoperative, the diagnosis. Okay, sometimes the MRI cannot give us a lot of information. And the other things is during operation, I think it's very difficult to evaluate the intraoperative cuff thickness and the quality. Sometimes, especially for the intra-substance tear. So I will give some rule. Maybe if each 1 millimeter of exposed footprint equaling roughly 10% of the tendon depth. Okay, so if there is a 7 millimeter of exposed the bone, so maybe equals to 50% of the tear. So if you measure intraoperatives, if you can see the bone exposure more than like 7 millimeters, so maybe you can suspect the tear more than 50%. Maybe you need to try the surgical repair. Okay. And also sometimes for the patient, the tendon quality is not as good as the normal patient, and especially at the bursar side tear. Sometimes after if you want to do the in situ repair, sometimes you will cause the tendon length mismatch, and this kind of condition sometimes will cause the postoperative stiffness. Okay, so the other issue is what is the best time for the surgery? A lot of partial tear patients, they will combine with the foreign shoulders. Maybe we can discuss this topic later. What is the best time for every surgeon to choose the surgical time to fix the patient rotator cuff tear with the foreign shoulders? Okay, and sometimes for the partial tear, we still need to pay much attention to the associated pathology, such as the biceps tendon and the labyrinth, or sometimes the capsules. So I will have two case sharing to everyone. Okay, this is a female 56 years old, is a bursar side partial tear with severe pain and foreign shoulders. Okay, so you can, from the MRI, you can see a very high signal around the footprint area. And from the actual, we can see the high signal around the bursar side. Okay, so because this patient was diagnosed at local clinic as a foreign shoulder and a very, very severe pain. So after the MRI, we can see a partial tear over the rotator cuff. And then because the intolerance of the pain, so the patient decided to choose the surgery. And then during the surgery, you can see the joint is very, very congestion, okay, and very severe adhesion. And this patient also have a type 3, the acromion. So it's when you're doing the arthroscope, it's very tight. It's very difficult to get into the subacromial space. So after the acromioplasty, we can see the very severe injury of the bursar side rotator cuff. Okay, so at this time, you can see all the footprint exposure but the articular side is still intact. So at this time, we need to try to do which technique, in situ or conversion to the full thickness. But for these patients, I can still put it back to the footprint, so I try to in situ repair. Unfortunately, the cases post-operative still have a very severe stiffness for about 1 year for recovery. Okay, so this is maybe that's what I mean. Maybe the cause of the postoperative stiffness is due to the tendon length mismatch. So maybe induce the stiffness. And this is the other case. This is a female left shoulder pain for a couple months and a failure of conservative treatment. From the MRI, just can suspect it's an articular side tear. During operation, after the debridement of the articular side rotator cuff, you can see a partial tear of the articular side. And when you go back to the subacromial space, you can see a very congestion and poor tendon quality. After cleaning up, you can see you will auto spontaneous conversion to a complete tendon tear. So this case is very interesting because he cannot afford to the All-Suture. So I tried the metal screw first, but unfortunately the intraoperative, the metal screw pull out. So means the patient has a very severe osteopenia. So I tried to put the All-Suture to the lateral cortex and then do a single rod for repair. But unfortunately, the case is after surgery, and the patient is very aggressive for the rehab, but still have a severe shoulder pain with limited range of motion. So I redo the MRI again, so we can see still have a tear about over the supraspinatus tendon. So because of the still discomfort, we recommend to do the second time the operation. And during each operative, we can see the bicep tendon have has a tear of the impending rupture, and also the retail side have a retail. So because we know the patient bone quality is not good, so I tried to do the bicep tendinotomy. I don't want to do any like tenodesis for this patient, and also we try to put the anchor in the more lateral cortex and to repair it or use the single row technique. But after surgery, the patient quite happy with the result. Okay, so my conclusion is not enough clinical data to determine the functional advantage between the two repair technique. Okay, basing the repair algorithm on the percentage of a tendon thickness is my preference for a surgical indication. A more conservative treatment is advised for the elite overhead throwing athletes. So further the prospective and the comparative studies with a large cohort population and long-term follow-up is advised. I think maybe this topic is everyone can give us a lot of idea, because I think this topic is still very interesting and still has a lot of controversial issues. Okay. Thanks for your attention. Okay. Okay, let's go to the Q&A section. Okay. So I think the first question is what is the maximum distance between the anchor in the medial row? I think maybe the Dr. Nadhaporn can give us some opinion.
Yeah, so the larger the distance between the medial row anchors, the better, because studies have shown if there's a larger footprint contact, there's better healing. So usually we need to keep a minimum of 1 centimeters in between the two anchor. If not, there will be, converging tunnels that will make the anchor loose. So we keep a minimum of 1 centimeters. Yeah. That's it. Do you all have anything to add with regards to this question?
Yeah. Dr. Nadhaporn?
Yes, I think that they asked about the medial row for the distance. So I think that's 1 to 1.5 cm will be the good locations that you can put the anchors, because if it is too close, sometimes it's very clumsy to manage the suture, and if it is too far, the compression over the tissue to the footprint will be very low, and you can have some not the sealing effect of the tissue to the bone, and the healing will not be good. So 1 to 1.5 is the maximum. Yeah.
I think this question is interesting for example, like in our Asian female, the footprint is often very small. So sometimes it's for the All-Suture, it's easier to put 2 anchors, but sometimes it's like for the screw type, it's difficult to put the 2 anchors. So if you guys have any like experience about when will you put one anchors, when will you put 2 anchors for the medial row? And Dr. Han?
Yeah. So for small tests, I will just do a single row repair. Or if I were to do a double row, I will just use a single anchor medial row, single anchor lateral row. That's for small tear. Because like what Dr. Wu has said, in Asians, the footprint is really small, the bones are really small. So I realized that if I use the screw-in anchor, only for very large tears I can put into. For moderate size, 2 to 2.5 centimeters, usually 1 screw-in anchor, I already take up the whole cartilage margin. I don't have much space. Yeah.
Right.
Okay.
I agree. The one thing that I observed from my my surgical practice is that if you have the very tight of the tendon, that you cannot pull it close to the footprint, sometimes even the small lesion, I use double roll. But in general, if it is a very small, just 1 to 1.5 or 2 centimeters, I use sometimes I use the tension band techniques for the single roll. I use it like the free suture and tie it and then pull it and put it on the lateral of the footprint. So that's the thing that I would do if it is not the big tear. But if it is a bigger tears like 2 centimeters, 2.5, I agree that two medium, 2 lateral, and use the suture bridge technique is the best one.
Okay. As we know, the COMED have a new All-Suture is a ribbon, right? Sometimes we have 3 sutures. Is this design will change your anchor numbers? For example, if you initially want to put 2 anchors, right now if you use the suture ribbon, we just put 1 suture is enough. What's your opinion? Yeah.
Right. I agree with that. Because of the width of the ribbon or even the tape is quite is 1.3 to 2 millimeters, like that. So it can have more compressive tension over the soft tissue. So if you think that the suture or the ribbon or the tape could handle the tension of the cuff, it's maybe just only 1 anchor with just double load of the ribbon is enough. Yeah.
Okay.
I agree.
Dr. Han?
Yeah, I will agree. But for the triple loaded suture anchor, I'll be more cautious to put just 1 anchor, because I think with 6 limbs of sutures passing through the tendon, there might be too much force on 1 suture anchor. And also, like Dr. Nadhaporn has mentioned about the seal effect, if the sutures are all spread apart from a single point, there might not be proper sealing of the repair. So if possible, I think still put 2 medial roll, 2 lateral roll for bigger tests. That's what I would do.
Okay. For me, the ribbon, I like it because for the first reason is we always have the first year residence. Sometimes you pull all the wrong sutures, so you still have the other chance for the cover repair. and then sometimes I think we still have the other question is how to avoid the dog ear. I think the triple row sometimes is a good anchor for us to, if after like the double row suture, if you still have a dog ear, sometimes I think the triple row can decrease the dog ear. I don't know what can maybe the 2 doctors can share your experience how to avoid the dog ear during the rotator cuff repair.
Me first.
Yeah.
Dog ear usually happen after you already repair them, and it's happened. It not just happen before you decide to use the triple load anchors.
Yeah.
So my experience about this, the dog ear happened after I finish my regular 2-2 and then still have some more tissue on the anterior or posterior cuff. And then we need to sometimes I use a free suture and make the free suture like the just only the horizontal, and then pull it on the more lateral and put with another pop slot or something. But it's very rare that I did it. But normally I know that from the previous literature they say that the small dog ear can heal spontaneously without doing anything, but you are not satisfied with the pictures that you find from the post-op, right? So you think you need to do something, you need to kill it, you need to cut the ears by do something. So from my standpoint, I think that if it is small, I leave it untreated. Yeah, that's it.
Where you put the other anchor to fix
it will be
dog
like the tension band techniques. I use it for the transosseous equivalent. So I suture with a free suture and then pull it on the lateral and use like the pop locks. to finish that. Yeah.
Okay. How about Dr. Han?
Yeah, so for me, before I put my anchors, I will sort of pull all the suture to simulate what it will look like if I anchor on the lateral roll. So if I see that there's a significant big dog ear, and then at that point before I put in my first anchor, I would have already put 2 single suture on both ends so that they will be all incorporated into 2 lateral roll anchor. Yeah, that's what I would do.
You
Yeah,
means
very,
that
very
you,
good tips.
yeah, Dr. Han, you means that you pull another extra
Yes.
suture? Okay. And
Yes.
make the lateral, two laterals, right?
Yes, 2 lateral, because the pop lock can take in 2 tapes, 2 suture minimum, or even 4 sutures. So I think for this pop lock anchor, it's quite versatile. So it can help us in reducing dog ears. Of course, there are some lateral anchor with a free suture in the anchor itself.
Yeah.
I will use that free suture to, after repairing everything, I will use that free suture to catch any dog ears. So it depends on the anchors that we use.
But in my opinion, I think the ball rotator cuff repair you did, the last dog ear will happen. Yeah, so it's interesting. So maybe for the initial cases, you do always have here dog ear, I have dog ear. But more and more cases accumulate. I think the dog ear, for your experience, I don't think the dog ear is a big problem. Okay, yeah. So the other problem is do you tie the medial roll or not? Or why? Okay.
I am waiting
Dr.
for
Han
this.
first.
Oh, Dr. Han first. Yeah.
No, you can go first, Dr. Nadhaporn. Yeah.
Okay. I know. I'm just talking that I'm waiting for this question to ask you as well. But now we will. Okay. I will answer that first. For the medial roll, I rarely tying the knot because from the review of the biomechanics of the double roll suture bridge techniques, we found that if we can share the tightness of the suture construct by leaving the medial roll untied, the lateral roll will take its base function and it can share the load between the medial and lateral. So the compression will be shared between medial and lateral, and the healing will be better than just load on the medial roll itself. And the other thing is that sometimes I found that if I got a very bad soft tissue, bad tendon, that when we tie it and we are not sure that it will heal, or it will be cut out like that. So and in that case, I usually not to try to tie it, except that one technique I used before is called double pulling techniques, that I use it for the medial and tie together. It must be tied both of the ends of the medial roll. So it's the only techniques that I still used for tying the medial roll. Out of that, I don't tie the medial roll. Yeah.
Yeah, same here. So I use tapes for my repair majority, most of the time. If I were to use the sutures, I will use it to tie a ripstop configuration. So it's same as the medial pulley, just that they are 2 separate individual horizontal matches that can sort of detension the tape. So that's the only time where I will tie the medial roll. Otherwise, I will try to do a knotless configuration if possible.
Yeah, for me, I routinely I still tight. Yeah, so because why? Because sometimes I have a international conference as a different surgeons. Some surgeon will say, "Don't you worry about the slippage of the sutures." So for my opinion, I totally agree with Dr. Han. If we use a more thick and more wider the surgical tape, maybe we can try the knotless the suture. But just for the suture, I think we still need to tie the medial roll. And the other issue is that I think the other problem is the strength of the lateral roll, the suture anchor. Okay, if the suture anchor is not strong enough, I think it's and also if the patient have osteoporosis, maybe you have a higher risk for the suture slippage. I'm wondering if you agree. Yeah, this is my personal opinion. Yeah.
They did say that for the small tape, like the high five suture, high five ribbon. Sorry, the ribbon can tie, right? But myself, I don't like to tie the ribbon because I think that it's still the tape. So the tape should use like the knotless, not the tying the knot. So the only thing that I mentioned is that if I need to use the tape, I try not to tie it at all. Yeah.
Okay, let's move to the next question. How can you avoid too much tension during the cup reconstruction? Can you share your experience?
I'll go first.
Yeah. Okay, Dr. Han.
Yeah, so I use a hydraulic arm holder. So usually when I repair, I will put the arm in a neutral position, at most just 10 degrees abduction, not more than that. And then I will just use finger tight pulling, tensioning of the suture before I mallet and deploy my lateral roll. So that will give a sort of a tension-free repair, because tension-free repair has been shown to be associated with lower rate of retears. Yeah, that's how I do. Any other tricks that you all have?
Dr. Nadhaporn?
Okay, I actually have no good explanation for this kind of the good tension, right? We don't know really that the good tension intraoperative may be because of you already immobilized the soft tissue very good, or you have the very thick soft tissue that it can bring to the footprint. But anyway, the best thing that I do is that I try to, we call tendon mapping. I try to grasp the tendon and pull it and move it around. If the tendon doesn't move back in the same bite that I hold the tendon, it shows that okay, it would be good for the tendon to be sit over here. So the tension should be fine. But if the tendon move back, the tension of the rotator cuff will be very high. So I may use a little bit more medial to put the medial anchor. You know what I mean? Like if we cannot move the tendon on the lateral angular footprint, I more medialize and put it a little bit more medial.
Okay. So for me, like maybe this question is a little bit tricky. Maybe it's asking about the whole construct or just the lateral roll. Yeah. Well, I think maybe the medial roll is not a big problem, but sometimes it's the overtension when you are putting the lateral roll. Sometimes you will see the whole construct will become compression too tight by the lateral roll screw. I think it sometimes depends on the different kind of implant. So some implant you can just hold it at a tight, and the tension won't increase after when you are inserted the screw. But sometimes some implant, when you screw in the implant, the whole construct, the tension will increase. So I think maybe it needs some like experience and for a different kind of implant. Yeah, that's my opinion. Okay, let's go to the number 4 question is, what are your tips to control bleeding in the subacromial space? Okay, Dr. Han first.
Yeah. So for me, I feel that prevention is better than controlling. We need to know where the bleeding will come from. So usually in the subacromial space will be the deltoid muscle. So when we clear the leading bursa, we make sure we don't clear the deltoid muscle as well. Then there's usually one important vessel that is near the thoracoacromial ligament, the CA ligament, which is the thoracic branch of the thoracoacromial artery. So over there, usually I'll just use my coagulation, just make sure I coag and identify the vessel to prevent that from happening. I mean, other things includes the pump pressure. When there's a lot of bleeding, I just increase the pump pressure to 50, 60, or even 80 temporarily. I will get my anesthetist to give me a hypotensive anesthesia. And then, yeah, I think probably that's about it. Do you all have any other tricks? I mean, adrenaline, I put adrenaline in my saline as well. Yeah.
I have no special trick for this kind of bleeding control. Yeah, the first thing that you know that if you have the frozen shoulder and you need to release it a little bit, the bleeders is much more than usual. So the higher pump pressure and you use the adrenaline, add on the normal saline that you soak in, and try to ask the anesthesiologist that, okay, we need a little bit hypotensive anesthesia. That is very ideal for that. Out of that, most common thing that it's happened is that when you go into the subacromial, sometimes you don't use the cannula. The cannula will be another one to stop, like the stopcock over that you can clog it, and the pressure will be spontaneously increased, and also the bleeders will be stopped, and as well as the destruction to the deltoid, especially for the anterior portal and the lateral portal. Sometimes the residents help us, and they try to make a little bit clear for the soft tissue birsectomy, and they aggressive remove of that kind of deltoid, and you need to stop that. So please keep your eyes on that procedure. Yeah, that's it.
Yeah, I think we have all very similar. For me, like we need to tell the anesthesia doctor maybe the control the blood pressure is around like a 100 to 120 around the keep it not too low not too high blood pressure, and why also add adrenaline to the normal thing using the pump system. Just only I think the most easily uncontrolled bleeding is when you're doing the acromioplasty, especially for the sciatic ligament area. Sometimes a lot of blood vessel over there. Sometimes very difficult to control bleeding. I think it's everyone have a very similar control bleeding technique. Okay, yeah. So let's go to the 5 questions. Is impartial rotator cuff tear is harmful for the healing of the rotator cuff when we do rotator cuff reconstruction?
I don't understand this question.
Yeah.
You mean that
maybe it maybe means the in situ repair have more harmful healing capacity. I don't know.
rotator cuff reconstruction is what?
I mean, maybe they ask about the in situ repair, just not completion or completion. Is there any difference about the tender healing? Yeah.
Okay. Take down or not? Okay.
Yeah. So, what about the Dr. Nadhaporn? What's your opinion about the partial tear? Yeah.
For partial repair, I'm talking about the bursal side repair first.
Okay. Yeah.
The bursal sides, from my standpoint, I think that if you would like to suture and to repair it in situ, it's quite very difficult for the tension of the soft tissue on the bursal side. If you don't release, it's more medial and take the tissue back to its own position. Even though you will have a very tight bursal repair, and it won't heal from the mechanics that it's the construct is too tight. So I think that if you would like to make it repair for the bursal side, I think that we should mobilize the soft tissue to make it more movable, and then the way that we put we suture the soft tissue, both of the articular and the bursal side, should have the close to be the same tension. That is the if you would like to repair just only the bursal side. But if the question is that harmful to take it off and repair them both, I think that I won't do that because of the normally the articular side of the cuff contains some part of the superior capsule. That is, this construction is very important for holding the tendon, and I normally don't try to take down if it's not nearly complete tear. That's it.
Yeah, Dr. Han.
Yeah, I think my theory is similar to Dr. Nadhaporn with regards to articular-sided and bursal-sided. If I can preserve, I will. But for older patients with a more degenerative type of tear, we know that the articular side, usually the quality is not that good. And also the blood supply is usually from the bursal side. So in older patients, I have a lower threshold to complete the tear, to remove away the unhealthy tissue and just repair it like a full thickness tear. That's what I will do for older patients with degenerative bursal-sided tear. Yeah. Otherwise, yeah.
Yeah, that's why I want to talking about this topic, because first one, I want to ask you guys if you have any opinion about how to differentiate how much tear intraoperatively. Just that's what in my lectures they maybe use the footprint exposure. Is you have any good technique or to know how much residual cuff you have intraoperated to decide what kind of surgical technique will you take? Yeah.
If we take a look from the subacromial for the bursal side tear,
yeah.
I confess that I don't know that how much percent. I cannot measure the percent of that. But for the articular side, I can see it from the MRI that, okay, looking at the footprint that is about 14 mm or 12 mm. And if it is half, it just, okay. If it's less than half, it's less than 50, I preserve that. More than 50, I will take down, something like that. But for the bursal side, normally I use the blunt trocar or something to probe around and move the tendon internal and externally and see that is there any weakest link. If they got the weakest link, or we feel like, okay, it's like the dimple or something like the tear, it's maybe, but I cannot measure that how much for that intraoperatively. Yeah.
Okay. Okay.
Yeah, same. I think it's very difficult to assess intraoperatively. So I base my decision more on the patient's age, the chronicity of tear, MI findings, quality of the tendon that I assess intraop. So I base it mainly on this to see whether a partial repair will lead to good healing. Yeah, otherwise, same as both of you, it's very difficult to assess intraoperatively.
Yeah, as I mentioned, my cases, the cases is a very severe, like a subacromial impingement, and all the bursal side cuff is almost gone, but you still cannot. It's still not the full thickness tear. Only the greater tuberosity. There is no cuff there. So this case is I can pull the normal graft cuff to cover, but until now I'm still wondering if this is right. Or should I need to take it down, just do a completion tear and repair? So maybe next time, if I have the same condition, I'm still wondering which one is much better. I don't know if you two have any like opinion about this kind of patients. Yeah.
No good answer.
No. But one thing that I found from the bursal side tear patient, I almost always perform the subacromial decompression because I know that it's the only external cause that can happen. But from the other cause, I normally not do the decompression. Yeah.
Same.
Okay. Let's move to the other question. Is do you have do calf repair in bursa tear bone have no symptom, and we know tear by chance. I think if for me, if the patient there is no symptom, I will depends on the patient's age. Yeah, but if the old age, maybe we just observation. But we still need to try, especially for the partial tear. We still can try the conservative treatment first. Maybe I don't know, your opinion. Yeah.
Yeah. Okay, me first. For 50%, I think it's from the MRI, because other than that, I don't know that how much. But MRI is rarely have the magic number that how much that you will repair or just leave it untreated. The patient has no symptoms. I will take a look at the configuration of the acromion shape as well. If it has a lateral downslope, or it has a very like the bird beak, or it has the osteophyte a lot, I think that it has a high progression for this kind of tear. So I advise that, okay, even though you don't have that symptoms right now, but I think that it will be the problem in the near future. But if you don't have that kind of thing, that is very rarely, we'll take a look and see what happened. So it depends on the configurations of the acromion as well. Yeah.
Okay, Dr. Han.
Yeah, for me, I'm less aggressive in the treatment of my patients. Usually, if they have no symptoms, I will tell them that surgery will not make them better. And every surgery, there's a risk. It might make them worse. You know, they get stiffness, infection, P. acnes, scar sensitivity. So I will usually tell the patient what the MRI show. But if they have no symptoms, I will just observe them. I will discuss with them. I will not be so aggressive in surgery if they have no symptoms. That's my point of take. Yeah.
Okay, so I think maybe I have a last question. It's about like a lecturer mentioned. As we know, the partial tear, this kind of patients sometimes will have a very severe condition combined with the frozen shoulders. So if the patient have a partial tear and also have a severe frozen shoulders, what is your surgical indication for this kind of patients? Yeah.
I normally start with the non-operative to treat the frozen shoulder first. With kind of sometimes I ask the patient, okay, I can use the oral corticosteroid for short term, like 10 days or 2 weeks, to reduce the inflammation as well as the aggressive rehabilitations. And if the pain is still there, and the pain plus some of, if they still have the bad pain, I try to put some of the local injection and see what's happened. If the pain still, or the weakness has much laser, I think that's the main problem is just the pain from the frozen shoulder. So I treat it without any surgery. But if the pain has subsided and the muscle is still not good function, like the jaw positive, I think that is the time for them to have the surgery. So I start with non-operative first. That's it.
Okay, Dr. Han.
Yeah, same here. So I will try at least 3 to 6 months of non-operative treatment, like physiotherapy, and then I'll assess if he didn't get any improvement at all, then I might just perform a surgery, do a arthrolysis manipulation at the same setting as the repair. But if he has improvement, then I will still continue non-operative treatment. I'm a bit more cautious about steroid injection, because as you know, it might lead to a higher chance of a re-tear if we repair the calf. So unless I'm certain that I'm not going to operate on the patient in the next 1 year, then I will inject a steroid injection. That's how my practice is.
Okay. Is there any question? Dr. Han and Dr. Amoy, do you have any further question?
No, I think it's a very good discussion. I learned a lot.
Okay.
Yeah.
We enjoy.
Sure.
Yeah.
Yeah, right.
Okay, so maybe the time is up. So Once again, thank you all for joining us today, and I hope that was a beneficial and a very meaningful learning experience for everyone. Okay, thank you, and have a very good weekend, whatever you are in the world. Okay, thank you. Okay,
Thank you. Stay safe.
bye.
Okay, bye-bye.